Welcome everyone to Art of Healing Cancer. Today we have Dr. Neha Sharma and Dr. Mandeep Singh Malhotra with us from Fortis Hospital, Vasant Kunj, New Delhi, India. And today Dr. Neha and Dr. Mandeep will explain us around the concept of bone preservation in oral cancer. Dr. Neha, would you like to throw some thoughts on that?
Thank you, Akpan. Hello, everyone. So today we are discussing a very important concept in oral cancer treatment, and that is the concept of bone preservation. So let's start with a case that we have very recently treated. And so this was a 48-year-old male patient who came to us with an ulcerated lesion in his mouth in the left retromolar area, which he had since a month. A biopsy was done, which was reported as squamous cell carcinoma. As a part of the radiological investigations, a PET scan was advised. You can see the PET scan on your screens right now. So it was reported that the tumor was just abutting the mandibular bone without any erosion or invasion of the bone as such. There are a few other images from the PET scan. Dr. Mandeep would like to say something about it.
Yeah, thank you, Neha. So whenever we take a decision whether to preserve the bone or remove the bone, so there are two important things which we take into consideration. First is the clinical examination, but in clinical examination, we see whether there is any gross bone erosion. But in oral cancer, especially in Indian oral cancer, which has tobacco chewing element, the mouth opening is restricted. So we rely more on the investigations because of the lack of proper clinical examination in clinics. So in this CT scan is the investigation of choice to understand whether the bone is involved or not. So if the tumor is not involving the bone, as in this case, so we go ahead and try to preserve the bone and do a marginal mandibulectomy in which we just remove the rim of the bone rather than removing the whole bone. Whereas if the scan shows a bone involvement or a bone erosion, then we don't try to preserve the bone. Then we end up removing the bone along with the tumor.
So, as Dr. Mandeep has just spoken, and depending on the radiological investigations, we took the patient up for surgery and decided to go ahead and do a marginal mandibulectomy, preserving the continuity of the mandibular bone. The defect was reconstructed with a free flap, and the patient recovered satisfactorily. These are a few intraoperative images that you can see of the surgery. However, when we got the histopathological report of the tumor was found to be invading the underlying bone. This was the picture of the specimen. Dr. Mandeep would like to say something about it.
Yeah, in this specimen, as we can see that there is a gross tumor involvement. So it is involving the cortex of the bone and it is reaching up to the lower part, that is the medullary cavity. So there is a flaw regarding whatever investigations we do. So it is said a 10% flaw. So it means that if the investigation is showing there is no bone involvement, there is a 10% probability that we end up having a bone involvement. And if the investigation is showing bone involvement, there is a 10% probability that we end up not having a bone involvement. So that is the limitations of the investigation. And then when we find such a situation that the tumor has involved the upper part of the cortex of the bone, it is eroded the bone and it is going right up to the medullary cavity. So it means that there is a aggressive tumor and there is a gross residual disease after that. So there's a lot of discussion in the literature regarding this. So I would just quote two things. So one, there is a paper from Sloan Kettering which shows that if there is a microscopic disease involvement, in that case we can go ahead with the adjuvant radiation or chemoradiation. Then we don't need to go ahead and remove the residual part of the bone. That means that there is a tumor in the oral cavity, a bone preservation surgery has been done, and in the histopath there is a microscopic disease involvement. There is no gross disease, residual disease. So in that case, the adjuvant radiation will take care of it. We will take care of the cancer control. We don't need to go ahead and remove the bone. Whereas there is another paper which was published in International Journal of Oral and Maxillofacial Surgery, which clearly suggests that if there is a gross residual bone involvement, that is, the tumor is involving the bone and it's reaching up to the medullary cavity, so in that case, it is better that we go ahead and remove the remaining bone for a better cancer control. Yeah.
So after all these extensive discussions that we did, we decided to go ahead and do a completion segmental mandibulectomy for this patient. And when we went inside the OT and we started the surgery, we saw that at the cut end, the resected end of the mandible, there was already a proliferative growth. We sent that tissue for a frozen section and it was reported malignant. So we did a posterior segmental mandibulectomy. We did a condyle preserving mandibulectomy, which leaves us with an option of a reconstruction at a later stage once the patient's treatment is over. And we used the masseteric and the sternocleidomastoid muscle flaps to buttress the area of the existing flap, which would prevent the formation of any orocutaneous fistula in that area.
So as in this pictures, these are picture of the specimen of the resected mandible, the residual resected mandible, which we took after the resection. So in this, we can clearly see that there is a proliferative growth in the over the medullary part of the bone, and it shows that there was a residual disease which is there. And this is a very correct decision on our part that we went ahead and resected the remnant bone. And yeah, so in coming to the discussion part of it, so though the radiological examination showed that there was no erosion of bone, and as I discussed earlier, that there is a 10% flaw in the investigations, that sometimes we end up having a bone involvement when the investigation shows it is not there. But the protocol wise and the decision still is remains the same, and we suggest the other persons to follow the same methodology, that if clinical examination and the radiology suggest that there is no bone involvement, so the first attempt should be to preserve the mandible rather than resecting the mandible. And then, as the histopathology sometimes comes unexpected, that there is a residual bone involvement or there is an aggressive disease, like in our case there is a extensive metastasis and even extranodal spread is there. So this means that it's an aggressive disease, and with the support of literature, we recommend that if such a situation comes for us further in our lifetime or for any other clinician, it is always better to go ahead and remove the remnant bone for better disease control. So if the bone is not involved, and even a microscopic bone involvement, it can be taken care by radiation. But if there is a gross tumor involvement of the bone, then it is better to remove the bone along with the tumor. Thank you.
All right. Dr. Mandeep, Dr. Neha, thank you so much for sharing your thoughts on this subject. I'm sure our audience would learn a lot on this subject through this video. And I request all our audience to subscribe to our channel to keep receiving a lot of these informative videos in time to come. Thank you so much and have a great day ahead. Bye-bye.
Thank you.